Dialysis is a process by which solute sand water are removed from the vascular space. It is used primarily as an artificial replacement for lost kidney function in people with acute and chronic renal failure. The main principles by which dialysis works are diffusion of solutes and ultrafiltration of fluid across a semi-permeable membrane. Blood flows on one side of a semi-permeable membrane and dialysis fluid flows on the other side. The performed hemodialysis vascular access is required, for which minor surgery is required. Almost always in the forearm, there are three possibilities.
Temporary catheters are indicated in patients who are likely to be on dialysis for only a brief period, are too ill to undergo placement of a permanent catheter, or have limited access opinions. Temporary catheters vary in size and are typically uncuffed and undented. They can be inserted at the bedside under sterile technique, preferably with direct ultrasound, with dance or fluoroscope, by an experienced practitioner to ensure accurate central placement. They are sutured into place and secured with a sterile occlusive dressing. Implant and graft, an artificial vessel that connects the artery and the vein. Arteriovenous fistula. Patients who require long-term dialysis may be candidates for placement on an arteriovenous fistula or graft. Arteriovenous fistula on grafts create permanent high blood flows. Arteriovenous connect which can be accessed used large bore needles to perform dialysis. Fistula and graft are never appropriate in the acute dialysis settings, as they take time to mature and provide adequate blood flow for dialysis. Such access should be placed by an experienced surgeon. In adult recurrent long-term dialysis, such access is preferable over catheters, as there is a lower risk of infection.
Once the machine has started, blood will flow from the arterial catheter limb through the port that allows for blood sampling and medication administration to the rural pump. A pre-membrane pressure sensor is located before the blood enters the filter. The blood then enters the filter where clearance and ultrafiltration occur. The filter receives dialysate from the machine, which has mixed the water and dialysate to the appropriate concentration. After flowing through the filter, the blood goes through the post-membrane pressure sensor and then an air detector. And if air is detected in the circuit, the machine will alarm and shut down. If no air is detected, the blood flows back to the patient by the venous catheter limb.
Pressure sensors monitor the pre- and post-filter pressures. Acute pressure must be maintained in the circuit to promote ultrafiltration and prevent clotting. The system will alarm if the pressure are too low or too high. Low and high pressure can indicate complications such as a clot in the filter or an occlusion in the catheter. Air sensor monitor the extracorporeal blood for air that may be introduced into the circuit. Bubbles may enter the system, ache through, and break in the circuit. If air is detected, the machine will alarm and the circuit will stop automatically to prevent air from being infused into the patient.
Temperature sensors monitor the extracorporeal blood, ensuring that the temperature remains stable during the session. Blood may cool down as it flows extravascularly, and if the machine gets too cool, some machines may be programmed to warm the blood. Or warmers might be placed around the tubing to prevent hypothermia, especially for small infants. Clearing the blood lines also can be employed for those with fever or malignant hyperthermia.